Good afternoon, and what I like to accomplish with this presentation, only two things. The first one, it is that we do have today knowledge about central pattern generator for locomotion. We do have a knowledge how the nervous system control the movement, how control moving, and I would like to bring to your interest that this new knowledge of human motor control should be part of your clinical work. The second thing I like to show how simple procedures can be applied in a person who is suffering from muscle weaknesses due to the progressive degeneration to modify, to upgrade motor control. And here this slide is showing under the a so-called healthy person with the intact nervous system and muscles too, and B is showing a person with muscle dystrophy who, what you are seeing, if you look down on the bottom, time 1 second, and application 1 millivolt. So both of them are recording during their so-called spontaneous gait, and the output of motor units for the affected person is much larger than in so-called one which is not affected. What it tells to you that activity here of nervous system to the common final path is larger, and they're maintaining and performing both the same motor task of ambulation. You can see there on the last one that the recording was made during the landing of heel, during the beginning of the midfoot and toes, so all dynamic of the foot. The next one is showing again A, B, C, D, E, F. And for instance, if we start with the F, it's another muscular dystrophy which has a very low motor unit output and is ambulatory too. So there is no correlation between the amount of output, but what we are going to see, what you're actually measuring, it is the performance in time, in space, and means the question is not only distance, but the question is how many different speeds in a certain distance you can perform. Only one normal person, an adult as well as a child, can have 5 different locomotor speeds which can generate and control. And it's not only a question, can you endure certain things, but it is how many different speeds of these 5 you can use. All this work was published, was coming from Linköping, from Sweden, by Professor Larsson in series of studies of healthy and affected one. Okay, let's go further. The other question is, what will happen if you compare maximal force performance at the reciprocal level? And this can be a very simple clinical test as well as laboratory one. And you go above, and it's a measure of isokinetic force, 3 times, as you can see, repeated. And you see reciprocal activity between tibial anterior triceps surae and coactivation of paraspinal and quadriceps. Now, how much maximal force can generate a child with muscular dystrophy? You see on the left side, it's a much less. And as you can see, this coactivation. This is a factor which you need to know when you're assessing performance, because a lot of this coactivation, which is a response to the pattern control of the movement, it is also a restriction for somebody who has a weak muscle. So you are not only inducing and evoking a motor output, such and such force, or such and such kinesiology, but with the pattern activation, you are suppressing this capability by your testing. Now, just to show to you how it's happening, here is a healthy person. And on the B is sitting on the chair, and first is asked to perform maximal force of dorsal flexion. And then you divide in 20, 40, 60, 80, and 100% of maximal force. And you're recording with the surface electrodes the amount of activity. And what you are seeing here, how you're recruiting in this healthy person, number of more proximal muscles. And the same thing is performed in the A, or the above one, which is a standing one. And you can see that recruitment of contralateral side naturally is appearing earlier. This is again simple method to find out the trigger level of your co-activation, which you would like to know when you are trying to assess this. But let's not complicate things. We already heard a lecture of docent Nates, whatever, I need to remember his name, and on the platform. And these things, for instance, this recording here, which I'm showing on the left side, on the posturography, and this is showing on the left side a healthy child, and on the right side is showing a standing dystrophic child. And what you see, so significant move to the anterior gravity line. Why? Definitely it's an integral. Definitely it's a very easy to repeat. And you don't need to have a platform. You can measure this also clinically. And this is something which we do not like to forget in muscular dystrophy, because kinesiology is not working here. It's working pattern of activity. Let me try to show this as much as I can clinically. If I like to go forward, I'm not more activated. Do you have the microphone in the hand?
Here you go.
Thank you very much. When I'm leaning forward, my paraspinals, my glutei, my hamstrings, my plantar flexors, tibia, triceps, sura, and so on, they're activated, and all in the front are suppressed. This is a pattern activity. It's not gluteus, it's not paraspinal, all together. And now, if I go backward, I'm going to activate all anterior compartment and suppress the posterior. Now, as you know very well, and I'm going to show, very early involvement in so-called proximal Duchenne dystrophy is a tibial anterior, and we are going to talk why. And if your tibial anterior is weak, and you have still good quadriceps, or at least rectus femoris, and you have still iliopsoas and so on, you'll not be able to stabilize yourself. You're going to be what you see here, to go anteriorly. And why is this? Because you can do this on yourself. If you inject your peroneal nerve with a 0.2, which was years back discovered in Queen Square for Parkinson, rigidity, and so on, if you do this and you only deafferent large fibers and not the small one and not the motor one, so you can be on the toes and the heels and so on, but if this happens, you will be surprised that you cannot move backwards, because your trigger muscle in this pattern is affected, and these large myelin fibers are going to activate. So you have different paresis and different paralysis depending from the motor task you are performing and allowing to happen. Venus was one of medicine men from Cleveland who has published several times in early 50s that how he can extend ambulation of muscular dystrophy children from age 12, if you have seen this, then when he started, and so on, up to 12 years by few simple orthoses. And what he was doing, he was trying to stabilize these trigger muscles of the pattern, which is used for the movement. Well, let's go further. This is showing the calculation of 20 healthy and 20 muscular dystrophy children about their activation of the peak by performing the task of leaning forward. And here is another thing which you don't think as a practicing physician, but it is not only leaning forward and backward, which you see for a healthy person performing on the A, and on the B, you see that your muscular dystrophy person is short in doing this forward and backward, but is equally good and even better doing on the side. And people who are working in physical therapy and who are knowing about procedures, how to apply the gait, by rotating these sagittal perturbances, you can advance very nice gait to a person who has a problem with the swing and stance. So there are residual functions which you are not aware, and you can document if they're present or not. Okay, let's go further. This is Dr. Dietz from Spinal Cord Injury Unit in Switzerland, who spent a lot of time on trying to study central pattern generator in spinal cord injury people. And he was studying here muscular dystrophy and comparing what will happen if you put to the person with a treadmill, and this treadmill is going with certain speed, and then you go backwards, you have a kind of reflex response on adapting. And what he was able to show, that there is no difference between dystrophic or person with the muscle weaknesses and control group. So this is telling to you that the nervous system for postural control is functioning perfect. Now this is the healthy in both conditions, as you can read, gait perturbers, and then, and then, as you can see, I will go once more back. This is the healthy, and this is the, you can, Dietz and Berger, they have done this. And you can see this time-wise, amplitude-wise, is not changed. Even the muscles are different. Okay. Now let's become for a time a classical physician. Physician who is looking with this manual muscle test from 0 to 5 about muscle weaknesses. And what he's seeing here, there are 20 subjects with the spinal muscular atrophy and with the muscular dystrophy. And showing different muscle, you can read, hopefully, from the above to erectus abdominal gluteus maximus and so on. And what it shows to you how in different 1, 2, 3, 4, 5, 6 SMA, spinal muscular atrophy, and then PMD, and how different muscles are different affected. Now let's choose a muscle which is a tibial anterior and compare with the triceps surae here on the bottom, the last one. As you can see, they are affected differently. The manual muscle test number is there on the right side. So their affection is not equal, it's different. Why? Why is different? And we asked this question about 40 years ago. And we wondered at that time, what is happening to intrafusal fibers of the muscle spindle? As you know, there is a receptor which is measuring the force and has a gamma innervation, very little, very diameter. And we asked the question, do we have in dystrophic child or adult who does not have more visible muscle fibers and no visible contraction, can we prove that they have a tendon jerk response? Because to have a tendon jerk response, you need to be able, or stretch reflex, to be able to activate the muscle spindle. And to activate, if it's sloppy there, you cannot do it. If you have intrafusal, you'll be able. And of course, you have very few muscle fiber there. You need to look at for so-called silent period, because after muscle spindle discharge, you have a suppression of ongoing activity. We published this in Brain, when it was Load Brain editor, and what we have found, that the intrafusal fiber, even the morphologically, Swash was reporting that in the hand that they have been affected, whatever has happened, we've been able to show that they are functionally working as you expect to work. This led us to the next question: what is a characteristic of intrafusal fibers? What are characteristics of platysma, which is not the same as the other, without fascia and the fibers and so on? Anyhow, this led us to another study, which we studied tibial anterior dorsal flexor, plantar flexor, distal muscles in proximal affection, and we have found that tibial anterior is one of the earliest muscles, as you can see there between triceps, sura, and so on, which is affected. And then it was work of Gerta Verbova, which has shown first on the red, and then here is also our professor showing in human being later and so on, that you can modify the phasic tibial anterior motor units with the low frequency of 8 Hertz, and this can be changed a little. Actually, work started in Hammersmith with Dubowitz and his colleague, and then was transferred to Ljubljana. And what we have shown, that by changing tibial anterior to the tonic muscle, you can resist the progression of the tibial anterior by dystrophy. Anyhow, let's go further. Here is a picture which tries to help you. You see these are extrafusal muscle, and then you see in the intrafusal with the gamma fiber and so on. Anyhow, what I told you so far, there are pattern movement which can be restored if you restored mechanically or biologically the trigger muscle and synchronize the motor task. The second thing it is, if you know how to modify property of the fibers, which have been existing already before, as a classical physician, you can also modify the output of the dystrophy. And what happened now is Winfried doesn't work more. Okay, can you try to do something? There are 3 more, 4, but I can try to finish. How many minutes I have? Anyhow, no, next one. Okay, this is, we can jump this. This is coming from Professor Verbova work and her students, PhD students, and what they have done using recording of the muscle cells in the dystrophic rat and measuring their level of excitability of membranes and other factors, and showing that after stimulation with such and such frequency, that they can change their properties, which is next one. Okay, the last thing are coming from electrophysiology of Professor Stolberg from Uppsala in Sweden, and our late Dr. Trontel from Ljubljana, which has studied ALS patients, and in this scanning, how they saw single muscle fibers, which means components of, as has been shown already this morning by our colleague from Institute, showing that reinnervation can happen in ALS, and this is another one. Particularly, they're saying, you see there is an arrow here on the back, and there are a lot of jittering, how they call this, in this bottom before you can see above a component buildup. And this is for them evidence for the dynamic regeneration in progressive diseases, ALS. So now what, again, I cannot do it. Where is, can you help me again? Stay here, because I need to finish. And I'm unable, as you can see. Anyhow, what I have shown to you, it is possible to modify motor units. It is possible to document regeneration. Why we don't using this? What is problem other than knowledge? And here's their example of regeneration which is happening, and we will, can you go to the next one? Okay, if you put all this together, what I try, and I'm happy to continue the discussion, it is that there are so many things affected, there's so many things non-affected, because body is not homogeneous. It's a heterogeneous from the organ as well as from the control. Moreover, if you ask what is the nervous system and motor control, it is conducting and processing. And this conducting and processing, you heard this morning from Professor Meyer and many others, you can simulate externally, and you can develop certain function, not more on the brain level, but you can go to the brainstem or to the spinal cord. We like to call this spinal brain. And what is important, it says his activities of human neurophysiological assessment of upper motor neuron. There is a word which we need, and we should make this in conclusion: assessment and diagnosis. What is a disease, and what is assessment of motor control in the disease, and what is participating. And this is what we say today, that we need to start to use models in our clinical trials, and not pathological diagnosis only. So today, we know much more about upper motor neuron, we know much more about lower motor neuron, and we know how to measure clinically and laboratory. So, and all these things is existing for the past 50 years. And next one, now what is restorative neurology? I should be trying to be very intimate. I'm a young neurologist in Ljubljana, under training, and this is 1957, 58, no intensive care, but it was possible. I've been responsible for the stroke people. It was possible to use the diuretic in electrolyte and so on, and many of stroke patients which will die, intraventricular hemorrhages and so on, it was possible to help them to survive. And I've been proud of this, and many nurses told me, go to him, go to him, he knows. But after 3 months, what I saw, such deformities, such outcomes, that then I asked the moral question or ethical question: do you have a right to treat a person if you are not possible to give a quality of life. And this was then beginning of restorative neurology in 1960. Now we have international organizations, congresses, and training people to do this, which is based on these two things. First, restorative neurology is defined as a branch of neurological sciences which applies active procedure to improve functions of the impaired nervous system through selective structural and functional modification or altered neurocontrol according to underlying mechanism. No according science, not according only symptoms, but underlying. This is a measurement, assessment of neurological deficits. If I've been trained to make good inventory of neurological deficit, I would like to train all of you how you can assess their generation. And the next thing it says, basic functional features of CNS to conduct and to process activities contribute to the sensory perception, significant and wide variety of movements from locomotion, skillful movement, and speech. So that's all for today, and we shall continue this afternoon and tomorrow to talk about this. But for the end of this lecture, we do have in our patient more biological resources than we are using. Now, this lecture told us before me, told us we can do a lot physically, neurophysiologically, pharmacologically, systemic and locally, functional neurosurgery, and neurobiology. You cannot do in multifactorial disease with one modality. Thank you.